Thank you, Mr. Chairman. It's a great pleasure to be there with our Italian friends. I hope that my English will be relatively easy to understand by French audience. I have no conflict of interest. The term super-refractory status epilepticus was first introduced during the London Colloquium on status epilepticus held in Oxford, and was defined as continuous of recurrent seizures lasting 24 hours or more following initiation of anesthetic drugs, including cases in which seizure control is attained after induction of anesthetic drugs, but recurs on weaning the patient of the anesthetic agent. Considering the timing of this, at the onset there is status epilepticus, and when failure first and second lines anti-epileptic drugs, this is named refractory status epilepticus about 30 minutes, 1 hour after. Then general anesthesia is generally introduced, at least for generalized convulsive or subtle status epilepticus. At 24 hours of failure, we are in a state of super-refractory status epilepticus. There are two other definitions. Late refractory status epilepticus, when failure lasts more than 2 days, and prolonged refractory status epilepticus, when failure is more than 7 days. The incidence rates of refractory status epilepticus have been studied in several cohort retrospective studies, and it ranges from 12 to 43% of overall status epilepticus. For super-refractory status epilepticus, we have a figure of about 20% based on only a very short cohort of patients in 2 studies. And for prolonged refractory status epilepticus lasting more than 7 days, we don't know really. Probably it's very rare. A Finnish population-based study has recorded on a 3-year database patients with refractory and super-refractory status epilepticus. 87 super-refractory forms were found, an annual incidence of 0.7, 100,000. The median age of patients was 57 years, and there was an equal number of men and women. So we have a few studies now, all are retrospective, to describe main etiologies and outcome of super-refractory status epilepticus. Epilepsy remains a major cause of epilepsy, with usually poor compliance to therapy. And it's a global important etiology of super-refractory forms. But probably the major is encephalitis, with high rates in all series, ranging from 20% to more than 60%. Stroke is observed, probably the third cause, but with a proportion less than the others. And we have, interestingly, to observe that unknown etiology are relatively frequent in super-refractory forms. Age of patients is relatively young, and probably younger. In the paper by Deborah Pugin, where there was a cohort of patients with refractory and super-refractory, there was a patient with super-refractory forms were really significantly younger than the others. Median status epilepticus duration were high, sometimes very, very high, such as in the paper by Kilbriggs and colleagues. And accordingly, median ICU length of stay was also elevated. Hospital mortality is very high, ranging from 34% to 52%. This is relatively homogeneous among the 5 cohorts. And finally, long-term good outcome was observed in about 20% of patients. An important point is to consider duration of status epilepticus and outcome. We know that usually outcome is the longer the longer the status epilepticus duration, is correlated with a poor prognosis. However, as displayed in these 2 studies, a study by Lay and colleagues and Kilbride and colleagues, some patients with very, very long status epilepticus duration can have, at long term, a good outcome. And the cutoff point is probably about 60, 90 days. Over 90 days, there was a prognostic is extremely, extremely poor. Why does status epilepticus become super-refractory? 2 questions can be asked. Is there a poor compliance to guidelines? Are there specific etiologies which by themselves carry a poor prognosis? There are some studies which have addressed the question of compliance to treatment, the correlation between compliance to treatment and the effect either on status epilepticus control or on outcome. And as you can see on this table, there were a similar number of positive and negative studies, a similar number which found a relationship between compliance to guidelines and outcome, and some other not. The more recent study by the Rossetti team did, with a large number of patients, did not find any difference about in group with good and poor compliance with regard to control of seizures and outcome. Anoxic causes are very frequently super-refractory. This is well known. Central nervous system inflammatory disorders are more refractory than other causes of status epilepticus. This has been demonstrated in 2 papers, paper by Pugin and papers by the Rossetti team recently published. What are the treatment goals in super-refractory? 4. Stop seizures, whether clinical or not. Prevent neurotoxicity and further brain damage. Treat the etiology whenever possible, for instance, inflammatory. Avoid or treat complications of prolonged general anesthesia. General anesthetics are the cornerstone of treatment of super-refractory and super-refractory status epilepticus, and mainly pentobarbital or thiopentol, midazolam, and propofol. Evidence about the use of these anesthetic drugs is scarce, since almost only a case report on case series. There was one prematurely stopped randomized trial. The study was prematurely stopped because the inclusion rate was too low. The rationale for general anesthesia is strong. There is a relationship between seizures duration and outcome. There is demonstrated brain damaging effects of prolonged seizures. And we know that anesthetic drugs are able to obtain a rapid control of seizures, thus assumed to prevent post-ictal brain damage. What about the evidence? A very well-known paper of Clayson published about 15 years ago, reviewed about 200 patients comparing effect of pentobarbital versus propofol or midazolam. What was observed was that treatment failure, breakthrough seizures, and treatment modification were more frequent in the propofol or midazolam group. Conversely, arterial hypotension was very, very higher in patients treated by barbiturates as compared with other anesthetic drugs. A more recent study, including about 1,000 patients with refractory or super-refractory status epilepticus, found that difference between the three drugs were not so major than the previous study. However, look at the last line. Look at the last line. Death during therapy was very, very higher in patients treated by barbiturates as compared with midazolam and propofol. There are comparison of case series. They are not randomized studies. Unfortunately, there was no mention of hypotension. This is a critical point. We have to be aware of propofol infusion syndrome that has been studied, mostly studied in patients with status epilepticus. In the paper by Rayer in Critical Care Medicine, 31 patients with refractory status epilepticus were treated by intravenous propofol. 14 displayed failure of propofol infusion syndrome, including 3 with sudden cardiac arrests. Infusion rate, infusion time, and cumulative dose were risk factors for propofol infusion syndrome. And 2 patients died presumably from So it is very important to observe close monitoring when using propofol, utilizing a reasonable dosage and very close monitoring. Is there a place for ketamine? Ketamine is used, has recently been used in some patients, and multi-center retrospective review has been recently published with 60 episodes of refractory status epilepticus. Permanent control was achieved of 57% of patients, and possible or likely response to ketamine was observed in 32% of them. Overall, good tolerance was observed, and mortality when reduced. That is not surprising when status epilepticus was controlled within 24 hours of ketamine starting. There is a controversy. No, there is no currently controversy with regard to general anesthesia in refractory status epilepticus and super-refractory status epilepticus. Currently, no control studies. We have no control studies to compare respective benefit-risk ratio of anesthetic drugs. The available case series are small sample. Causes of poor outcome on death can depend also more on etiology. For instance, anoxic brain injury, tumors, and so on. Or treatment-related complications than poor or late status epilepticus control. And finally, 3 recent papers could add some evidence to this question. The first one is a paper by Raoul Sutter, recently published in Neurology. It was a single-center cohort of 171 patients with status epilepticus, 37% treated with anesthetic drugs. Patients with anesthetic drugs have more infection, 43% versus 11%. They also display a threefold relative risk for death independent of possible confounders. This was a juice test for confounding factors. It was duration, severity of status epilepticus, non-anesthetic, third-line anti-epileptic drugs, critical medical conditions, and without significant effect modification by different grades of status epilepticus severity and etiologies. A similar result was found in the court by Marchi and colleagues from Rossetti teams who demonstrated that therapeutic coma using anti-anesthetic drugs was associated with a 7-fold risk of new disability and a 9-fold risk of mortality. This was adjusted for potential confounding factors. And finally, in our team, we performed a multi-center retrospective study, cohort of generalist convulsed prolonged status epilepticus, 78 patients all treated by anesthetic drugs and mechanical ventilation, and we found that there was only one independent risk factor of long-term poor outcome. This was vasopressor use. And it is interesting to observe causes of hospital mortality. 41 patients died. 26 of them died from sepsis-related multi-organ failure, 8 from car withdrawal, 2 from sudden cardiac arrest, 1 from brain death, and 4 for unknown reasons. It's important to observe that only 1 patient died directly from neurologic causes. And it's interesting also to observe that status epilepticus was previously resolved in 20 patients who ultimately died. More questions than answers, sure. Are patients with specific status epilepticus types or specific etiologies are at higher risk for anesthetic drugs-related adverse effects? Can early administration of new generation of broad-spectrum anti-epileptic drugs reduce the use, the rescue with anesthetic drugs? Does the increased mortality caused by anesthetic drugs outweigh the mortality resulting from treatment-refractory status epilepticus? Should we favor prolonged status epilepticus over the use of anesthetic drugs in patients with certain risk profile? In the future, we will have to address all these questions. Non-anesthetic therapies, they are considered often as rescue therapy, and evidence-based of their use is very, very poor, since we have almost only case reports, anecdotal reports. There are no randomized trial, and in a short series, we observe often the same number of success and failures. So it's very difficult to, and I have no time to further discuss this point in details. So, to conclude, we can summarize what is considered as the best treatment today. General anesthesia, despite the controversy, remains the cornerstone of treatment, including potential consideration of ketamine. Anti-epileptic drugs and full ICU support. It's important to maintain in the refractory forms a treatment with 2 or perhaps 3 anti-epileptic drugs. It's important to investigate urgently the cause. When cause is identified, try to treat cause whenever possible. When no cause are identified, you can give magnesium which where the result with magnesium are clearly less than in eclampsia, clearly less. You can consider steroids or immunological approach, therapeutic approach in patients we suspected from encephalitis, where even with no etiology proven. Consider neurosurgery in lesional status epilepticus and consider hypothermia and ketogenic diet. And other therapy can be ultimately considered. On the last point, when to stop treatment of super-refractory status epilepticus. First, consider the prognosis of etiology by itself, such as rapidly progressive brain tumors, devastating stroke, anoxic ischemic brain injury, can be major factors to help to decide to withdraw care. Consider patient age, comorbidities, brain imaging, and status epilepticus duration. And third, always keep in mind that despite overall poor prognosis, relatively young patients with normal or no major perturbation of brain imaging may have a satisfactory recovery after months of sustained status epilepticus. Thank you for your attention.